Dr. Kristine Dalton is an associate professor in the School of Optometry and Vision Science at the University of Waterloo. And she has had a long experience um, in studying vision and motor performance. We were just talking at intermission about the interaction of both vision and movement of the eyes. And she has actually founded the Sports Vision Clinic at the University of Waterloo in 2004. She's published over 20 papers and given 80 conference presentations, supervised 40 graduate and undergraduate students. Her research interests include sports performance, traumatic brain injury rehabilitation, and able-bodied, and I'm pleased to say para-sport and Paralympic classification for athletes with vision impairment. What a great contribution. And her work is helping to develop one of the first sports-specific classification systems for para-athletes with vision impairment, as well as national and international guidelines on concussion management for para-athletes and in optometric clinical practice. So that's quite a wonderful life that you have led. And thank you for all those contributions. And thank you for contributing to our research, because you're part and parcel of what we're currently doing. So Kristine, please come and give your talk.
Thank you for that kind introduction, Charles. It's an honor and a pleasure to be here with you today. The vision and system and how it's impacted by concussion is a personal passion of mine. It's where I spend a lot of my time clinically working in a rehab space, but where I also wear my scientist hat to see if we can try and find numbers and evidence to support what needs to be done clinically. And I'm going to try and share a little bit of the background science as well as some of the research we're doing with you today. I have funding from a variety of different sources, including National Institutes of Health and Vision Therapy Canada. And I will talk about some of the work in some of these, but I have no financial disclosures from those. I am also a co-inventor of a dynamic visual acuity test, so a visual acuity test with moving letters. I will speak to one study done with this test, actually not in my lab, but I collaborated on a little bit later on. So when we think about visual dysfunction following concussion, up to 90% of patients who experience concussion at some point in their recovery journey will experience vision symptoms, regardless of their age, their injury mechanism, or their injury severity. Some of those will go away, some of those will persist. And when we think about the common vision problems that patients experience post-concussion, the most common ones are those ocular motility problems, including our convergence insufficiency, divergence issues, vergence issues, as well as saccadic dysfunctions, pursuit dysfunctions, and ocular motor dysfunctions. We see accommodative disorders are common in this group, perhaps including from an optometry lens, I think about accommodation being intimately connected to our prescriptions and our refractive corrections, but accommodation or refractive issues are present. We see light sensitivity, and we also see vestibular deficits in motion sensitivities. And these all contribute to a number of symptoms, including headaches, which we see across this population, but issues with concentrating and focusing, difficulties tracking objects, difficulties with balance and spatial awareness as well. And if we think of some of the work, so there's been some work done in this area. This was a nice piece of work done by Kristine Master's group in pediatrics with our adolescents with concussion. And they found that vision disorders, including accommodation, convergence, and saccadic dysfunction, were present in quite a large number of their population. But what was also really interesting was that 46% of the kids in this study had more than one vision disorder. So it wasn't just a singular entity, but there were multiple factors combining in the visual deficits in these kids. We just had a wonderful talk from Chloe about some of the photosensitivity work, but that she's doing with computer screen intolerance, and photosensitivity really is common following concussion. It can be persistent and predictive of prolonged recovery. It's also typically seems to be one of the challenges of photosensitivity as a clinician is it's really hard to quantify as a scientist or a clinician. We don't really have a good objective measure of it. And so often we rely on patients telling us about it, right? And maybe screen tolerance is a better objective measure because we can measure how long someone's at a screen. So because we can't quantify it, it also limits our ability to develop evidence-based treatments, but clinically, typically we'll use tints, filters, sometimes avoidance early on, but often progressive exposure, like Dr. Ritter was talking about, where we want to encourage patients to engage with lights in different ways that they feel safe within their symptom tolerance. And then those non-LED, non-flickering screens may also be another treatment, as well as some of the adaptations that Chloe talked about. This is some other work that's come out of Kristine Master's lab, and it's a really interesting group. It was a retrospective review of 432 randomly selected patient files presenting for visual assessments post-concussion. And they found that of their 432 files, actually 88% of them, so these weren't just vision assessments, they were concussion broadly, had visual or vestibular deficits present in their assessment. And they did a really nice cluster analysis on the group, which is the image presented here. And basically, if it's light gray, the deficit was present. If it was black, it wasn't. But they found some interesting subgroups within this. So there was a vision group, a vestibular group, and actually a subgroup of the vestibular group that had both vestibular and vision symptoms. So this really highlights that the vision system and the vestibular system are really closely linked. And what came out of this work, actually, which is really interesting, is that they also found that the presence of a vision or vestibular deficit early on following concussion seemed to be predictive of prolonged recovery in their cohort. And we know that those with persisting post-concussion symptoms are obviously at poor health-related quality of life across all age groups. So this was really profound to see come out of this group in the other Kristine Master's work. But it's not just the accommodation, ocular motor, and convergence deficits we're seeing. We're seeing other issues post-concussion in the vision system. So we're seeing pupillary deficits. Chloe alluded to some of the mechanisms that are being explored right now to try and understand where those deficits are coming from. We're seeing studies demonstrating that there's reduced contrast sensitivity after concussion, particularly after multiple injuries or long-term changes. We're seeing changes in the retinal nerve fiber layer in its thickness, the optic nerve volume, and the vasculature of the retinal vessels. We're seeing changes in different studies if you look at visual evoked potentials, so signals running from the eye to the brain, visual processing changes, as well as primary visual pathway changes when we're starting to do imaging with MRI. So there is profound impact on the visual system right from entry to the retina all the way back to the brain and how we use it. This was work that Dr. Tatter actually shared with me that just came out in January. So this was a study by Marcel et al. Where it was a prospective study, case control study at a level 1 trauma research hospital, where they looked at people with concussion and a control group. They did an in-depth clinical assessment that included clinical measures of convergence, accommodation, contrast sensitivity, but they also imaged the retina with OCT. They looked at visually evoked potentials, visual field, and MRI. And they were seeing in this group that they had those clinical measures, so reduced convergence, break and recovery points, decreased contrast sensitivity, and issues with their visual evoked potentials. But they also found that there were issues with nerve fiber layer and brain cortical volumes. And they employed a machine learning technique here, which was really interesting. And so in their population, they found a group that presented with more clinical metrics, a group that presented with more imaging metrics. But when they combined them both, they actually had better sensitivity and specificity in differentiating who had vision issues, and found that about 78% of participants had abnormal scores on one of their metrics, arguing for the importance of a comprehensive visual assessment, not just the front-end clinical piece, but that we really need the retinal and the brain imaging as well to understand what's going on here. So where my hat is and where my passion is I'm also a clinical optometrist. And it's really interesting when we look at the history of vision and concussion disorders. Optometrists, depending on where you work, are still not typically, not always involved in care. We're definitely not your acute care person, right? And I don't think optometrists should be seeing these people in the first week or 2 weeks of injury. It's not really our role. When we do get involved, it's typically those patients with persisting post-concussion symptoms, and there we're getting involved as part of a multidisciplinary care team. When we look at what an optometry assessment should include for these patients, what we should be thinking about, it really should include a complete vision exam, including a retinal assessment with a dilated fundus exam, visual field assessment, imaging if you've got it now, OCT, but certainly ocular health, and really importantly, refraction as well. Then we need to think about the binocular vision, so how the two eyes are working together. That's your convergence, your accommodation assessments, as well as your oculomotor assessments. And then thinking about screening or assessing for those other visual deficits like motion sensitivity, photosensitivity, et cetera. So we really need to be looking holistically at the whole system in our assessments. And I just want to show you this for a minute. And this is what it's like to read with a convergence issue. It's not fun, right? It's really challenging. Yeah, it's really difficult. And this is if your eyes don't turn in and line up properly to read something. It can be really aggravating and irritating to try and read and process information. And these convergence deficits, including convergence insufficiency, so our vergence system is essentially what turns our eyes in to converge and then diverges our eyes or turns them back out so we see clearly at distance. And it keeps our macula, which is our sweet spot of our vision from each eye, on what we're looking at. And as long as the macula is on what we're looking at from each eye, we see single and clear. The two maculas don't line up on an object, we get double vision, which is what happens with convergence insufficiency. And so typically we'll measure this clinically with a near point of convergence test, or we can use prisms, but you're bringing a detailed object in towards the eye, seeing how long someone can keep it single and clear. And then we're going to bring it back away once it goes double and say, when does it come back to being single, right? So where does it split into two? And then where does it become one again? Typically, normally we'd think it would be, you could keep it single till about 5 centimeters from your brow, right? And then about 7 centimeters from your brow is where it should come back in recovery points. Clinical norms are less than 10 and a break point, a recovery point within 2 centimeters of your break. But what we're seeing across lots of different studies is that the break and recovery points can be really abnormal following concussion. And these convergence insufficiency deficits are associated strongly with accommodation deficits, pseudomyopia, so accommodative spasm or an abnormal myopic refractive error, as well as vestibular dysfunction. This is an accommodation deficit now. So this is more consistent with when all of us will get old enough to need reading glasses one day in our lifetime. And this is accommodation deficits are essentially an early onset of needing that reading glasses. The focusing system for near isn't working accurately. And so when you try to read, things aren't double, but they're also not clear and in focus. And accommodation can be assessed in a variety of ways. I'm going to talk a little bit about the near point of accommodation measure here, which is essentially measuring the 1 rep max of your accommodation system, how close you can get text to you and keep it single and clear. We are seeing in a lot of studies that a reduced 1 rep max or reduced amplitude of accommodation is common following concussion, associated with those convergence disorders, reduced stereopsis, reduced accommodative facility, which is more of a changing accommodation test or an endurance test, and also associated with refractive error changes. What's really interesting when we start talking about accommodation is this underlying piece of refractive error. And this is where I start to, my clinical hat gets really excited sometimes, because there's evidence to show that some patients demonstrate a myopic shift after concussion, which is typically seen if the accommodative system sort of spasms or Charlie horses and forces a sort of a near point focus while you're looking at distance. We call that pseudomyopia. So it's not a true myopia that's driven by an eye elongation, but actually a muscular driven myopia. And if you put in cycloplegic drops to relax the accommodation system, that myopic prescription at distance actually goes away. It can be calcitrant, so it can be transient and improve with time, but more often it's persistent and will typically, if you cycloplege them, come back unless you're doing something to correct it. The majority of subjects in the studies that we've seen, these are also, they've looked at military veterans and other causes of concussion, typically between 1 to 2 diopters at distance, but that's enough to drop your visual acuity by 2 or 3 lines with the spasm in the accommodation system at distance. And then it's associated with knock-on accommodation defects at near because the accommodation system just isn't working as well. But there are case reports of being up to 10 diopters of a shift of accommodation. They're very rare, more within the 1 to 2 diopter range, but there are certainly these ranges. And it's found, interestingly, they're seeing that there seems to be mechanisms driving it, different mechanisms. So it's more frequent in blast-related traumatic brain injuries than non-blast-related TBI in military veterans. And interestingly, in those blast-related veteran TBIs, the number of blast-related TBIs was associated with the strength of the accommodative spasm as well. So we seem to be having, at least in some patients, this hyperactivity of the accommodative system. But equally, there's another group that seems to have a reduced activity in the accommodative system. So there may be a couple of mechanisms driving changes in our accommodative systems. This was some work out of Boston's Children's Hospital looking at children with accommodation deficits. And this is people who are long-sighted normally, don't wear glasses, but 64% of them had accommodative deficiencies post-concussion, whether that's related to the uncorrected long-sightedness to begin with, or secondary to the concussion, but they were not symptomatic, not wearing glasses to begin with, and then have these accommodative deficiencies post-concussion. And so it was found in this study that corrections of small hyperopic refractive errors can actually improve accommodative function, support relieving symptoms, and shorten recovery. And so we seem to have these two impacts on the accommodative system, and we aren't sure, quite possibly they're two different mechanisms, one driving a hyperactivity, one driving an underactivity, but both of which can be modified with spectacle correction and improve symptoms and quality of life. So where we're sitting right now is, although that we've got some of this data and we're hoping to analyze it all and help contribute to some of the guidelines, where we're starting at is really from an optometry perspective, an accurate refraction is critical, right? Getting that spectacle prescription corrected accurately, correcting for any spasm of accommodation or latency in accommodation, getting that prescription bang on is critical, and that cycloplegic refraction looks like it's beneficial in this population. If you're doing a tint trial, you need to do that with your prescription and update it with your glasses. But there's a wide variety of colors. There doesn't seem to be a one-size-fits-all color post-concussion. And I think that's important, right? We let patients choose what they're most comfortable in wearing if they want one. We recommend using relieving prisms as needed. I didn't speak to our prism data, but we typically in our clinic don't start with yoked prism as a first line treatment. We start with refractive correction, tints, and vision therapy first. Yoke prism comes in later if we need it. If we're prescribing prisms for misalignments of the eyes, though, those are relieving prisms, and that's typically what we'll start with early on. But we tend to work with the philosophy, change the glasses first, and then reassess once they've been adapted to their new glasses, and then initiate vision therapy as needed on an individualized approach. When we think about vision therapy is perhaps one of the things I do a lot of, and I think it's really important, but is also one of the things that makes me the most nervous to talk about because it has a very diversity of reputation. There's a whole bunch of people using it in different ways, and it can be great, and it can be, even within my own profession, sometimes I think way overprescribed, and I'm going, I don't understand, right? Like, we have no real good guidelines. Vision therapy is also not a controlled act. So it's not just prescribed by optometrists, it's also prescribed by OTs and physios and athletic therapists. And so there's a huge range and scope within what we consider vision therapy, which is not always helpful when we talk about vision therapy, and why I get nervous talking about it. This was a nice study that was done in 2017 by Galloway, Scheinman, and Mitchell. And again, a retrospective review of 218 patients with post-concussion vision problems. And then vision therapy for these patients is recommended on the basis of clinical findings. And they found in their clinical findings, about 82% of these patients had some sort of ocular motor dysfunction, either be it a binocular vision issue, an accommodative issue, or an eye movement issue. And vision therapy was recommended in 4 to 5 people. And about 54% of those only completed the vision therapy program. They found in those who completed vision therapy that their symptoms, their near point of convergence, positive fusional vergence, which is another 1 rep max measure of the vergence system, and accommodative amplitude, which we talked about, all improved. And that the changes were both clinically and statistically significant, but there was no one-size-fits-all vision therapy program these people were put through. It was tailored and targeted to the deficits they had based on their entering assessment. So based on this and some of the other literature out there, and I would say from my clinical experience, vision therapy appears to be more effective for things like accommodative dysfunction, convergence insufficiency, and oculomotor dysfunctions. They are more trainable and tend to respond better to therapy. And in improving those, we seem to be able to impact post-concussion symptoms in some patients. But it doesn't work for everybody, and it will never work for everybody. But typically when we do a VT program, or when I'm recommending a VT program, they're typically exercises that can be done in office or at home. And we really focus on establishing good monocular function first, followed by binocular function, and then incorporating visual spatial awareness tasks or vestibular stuff as needed. But it really is, the way I teach my students, the way we approach vision therapy is kind of like, we're going to assess everything. Imagine you're going to a gym and meeting a personal trainer. They're going to take a good look at where your weaknesses are, one-sided or both-sided deficits, and then they're going to target a program that's specific to you and your goals. And that's really the approach we're taking with vision therapy at the school. We are collecting some data on this now. In that same 119 concussed patients, we've got vision therapy data ongoing for them, and it was recommended in about 94% of them. It wasn't done in 94% of them, but we are seeing that, a number of them actually make progression, actually return to, so all of our patients in our clinic are persisting symptoms, sometimes 2 or 3 years out. And we're seeing a chunk of those patients return to clinically normal values. We're also seeing patients improve, but then discontinue therapy because they're not making full recovery, which is fine. But one of the interesting things I found is that in our program, or at least in the preliminary data analysis, we have a mix of patients doing therapy in office or at home, and either works, right? We're seeing consistent success rates across both groups. So in office is typically coming in once or every week or every other week, and then doing exercises at home. At home is we see you every 4 to 6 weeks. We set you up with a custom program and you go away and do it. And both models seem to be successful in our patients. However, we do know, right, as of right now, there's no set number of duration of vision therapy that works for every patient. We're seeing our patients in this study are somewhere probably between 5 to 10 visits total. Those are spread out over a number of months, but we're not seeing 60, 70 vision therapy visits in all patients. Typically, what we recommend is that if you are doing vision therapy, reassess your numbers, check your progress every 1 to 2 months to determine if you need to continue, right? Check in regularly, have a tailored approach, and then see if you need to continue from there. If you're going to continue vision therapy past an initial pass, it really should involve a reassessment of function, confirmation there's still deficits present, along with a conversation with the patient about how they need to proceed, because vision therapy is not their only therapy. They're going to often be in physio, massage, and OT and doing exercises and things from everywhere else. And we're only a piece of that equation, right? Our work needs to work for the patient, right? And if we're putting too much on their plate, we're not going to help them get better, right? So we need to step back and work within their team approach to help them move forward. I will say there's other treatments out there that you'll hear of associated strongly with vision therapy, things like binasal occlusion, angioprisms, and syntonics. None of these are in my front line. I think I've attempted binasal occlusion twice in the number of patients I've seen. These are last resort treatments for me, really, because there's really even more limited evidence supporting these, and really strongly need research if we're going to go down this route. I tried to look even at some of the research for syntonics, and one of the challenges they found was that the devices are not all made the same with the same color consistency. So it's even harder to evaluate whether it works or not when the devices are not equally putting out the same wavelength of color, right? So these are certainly treatments that are out there, but I don't think there's evidence supporting them as a first line treatment. These are things when other more conventional methods have failed, things we should possibly be considering. I'm going to throw a couple other pieces out there just to give you an idea of some of the other places where vision can be involved. So this is that dynamic visual acuity test I alluded to, and some work done at Wilfrid Laurier, looking at athletes with a history of concussion and athletes with no history of concussion, all recovered. Those who had concussion were within the last 3 years, and we were assessing dynamic visual acuity. So an acuity chart where the letters move, not the head spinning, but the letters themselves are moving. Patient is sitting still. In seated and standing positions, and we also measured balance in those standing positions. We use 2 types of targets, so one where the letter moves randomly around the screen and one where it moves horizontally across the screen. And interestingly, in our athletes with a history of concussion, who were still recovered, when they were standing compared to their seated posture, their dynamic visual acuity actually decreased relative to what it was when they were seated, with just that postural change on the force plate. And we weren't seeing that change of dynamic visual acuity within the group that didn't have concussion, suggesting that some athletes with sports-related concussion may actually have lingering visual deficits or visual cognitive deficits where they're starting to have to make trade-off decisions between maintaining my balance and seeing as clear, or seeing as clear and sacrificing my balance. And there's been some interesting work coming out of Mike Ginelli's lab looking at the interaction between dynamic visual tasks and balance in groups, showing that vision balance trade-off when we do a cognitively challenging vision task along with a balance task. But you could imagine if an athlete's ability to see moving targets in detail is still reduced, maybe those aren't the athletes that should be back on the field of play, right? If they have to sacrifice their vision to maintain their balance, this may give us some interesting avenues to explore for making more objective return to play decisions in some of these individuals. And then some of the other work we've done at the school is actually rooted in more traditional psychophysics, trying to understand where the visual processing deficits are occurring. So we were looking at global form and global motion tasks. So global form tasks are typically, can you detect a pattern? So this is a pattern of rings. This is a pattern of crosses here. And what happens is these are pretty coherent, almost 100% dots are aligned in the pattern, and we introduce noise dots into those patterns. And so we scatter because of the noise dots, the patterns become more scattered and harder to interpret. And we're trying to measure a threshold where you can actually accurately detect that pattern consistently relative to the relevant noise. Same idea in motion, except it's a coherent motion direction, and then we add in noise and we get the scattering in motion. Typically, global motion tasks are seen as being thought of as being dorsal stream, global form or ventral stream processing. And what we found in this group of individuals, again, some with symptoms, mild TBI and symptoms versus controls, is that there were actually deficits in both of these processing streams, on both the ventral and dorsal streams. And it was also associated with clinical deficits like reduced stereopsis, near point of convergence, and vergence facility and accommodation deficits. So it's helping to support the idea that a concussion is not just a singular line through the brain, but that there is this holistic multi-processing system, multi-processing deficits being presented with concussion. And the last piece I'll just wrap up with here is also the para-athlete piece. We don't talk a lot about individuals with vision impairment or other physical or intellectual disabilities, but what we're starting to learn as this literature is starting to come out is that concussion incidence in individuals in parasport events is actually equal or comparable to those in able-bodied sport, and may actually be higher than normal in those in able-bodied sport and athletes with vision impairment. So they are one of the higher risk groups for concussion in sport. And what makes that interesting or challenging is many of what we would consider classic concussion symptoms are really hard to recognize in athletes with vision impairment. So double vision may be a normal state of affairs for someone with a vision impairment. Blurry vision may be a normal state of affairs for someone with a vision impairment. A blown pupil or pupil defects or non-responsive pupils may be normal for someone with profound visual impairment. And so our red flags that all relate to the vision system may actually be those athletes' status quo pre-injury, making it really challenging to try and assess and understand what is a concussion and how does it present in these individuals who are likely at a higher risk than some of our other athletes of concussion. And the Concussion and Parasport group published their first position paper, and it's not just on vision impairment, it's on physical impairments and intellectual impairments as well, going through our traditional metrics, which are the best tools we have, but recommending modifications and how they should be used in athletes with these different types of impairments. Again, along those lines, if you're trying to assess balance, you can't do a best test in an athlete in a wheelchair. So how do you assess balance in an athlete in a wheelchair? It's still relevant to their performance, but how do you assess it in a meaningful way? Out of that group, and the piece particularly in the athletes in impairment and some of the work we've been doing is that optometric assessment, if anything, is even more important to be able to differentiate what's concussion and what's ocular disease. And trying to figure out where the differentiation is and whether there's new changes in the disease related to their concussion presentation or not. Our athletes with vision impairment often need unique accommodations during recovery due to increased demand, either cognitively or physically when navigating spaces. It's a lot harder to navigate a space following concussion with a cane, or they may need to rely on guides and supports now to navigate more familiar environments because their spatial awareness is disrupted. They may also need reading assistance, things like that, because reading in Braille is very different than reading normally. And there's some really nice resources from the Canadian Blind Sports Association available should we be working with those individuals. And I will wrap up there. Thank you.
Fantastic. Thank you very much, Kristine. I'm going to take the prerogative of asking the first question. I had two patients last week who both complained of nearsightedness after concussion. Both were wearing glasses. What do I do?
I think those are the patients where a cycloplegic refraction helps, because that nearsightedness after concussion may be that accommodative spasm. So a careful refraction really makes a big difference. Taking the time to do it with cycloplegic drops, relax the accommodative system, and see if there's any changes in prescription would be my number one start point.
Thank you. Carmela?
Thanks. I think this is great. Seeing patients, in the lens of, holistic views, these patients who have vision changes also have symptoms that sound vestibular. And so I often, hear, one set of recommendations from the vestibular world and then the other set from the vision. And I'm thinking, how is the poor patient supposed to navigate that? And a lot of times the patients are only getting vision assessment or vestibular. We try to, send them to both, but how many times do you guys integrate that information?
I'm trying to encourage it more. It's still unfortunately, partly because of the way my profession is also kind of grown up and very eyeball centered. We aren't always the first at the table and want to work with everybody in the concussion spaces. But I try really hard to, at least within our practice personally, to integrate and work with the physiotherapy teams to make sure that if we'll do a vestibular screening in our clinical assessments, and if I'm seeing stuff there, as long as refractive error is corrected, I'm going to ask and see if they're being referred to vestibular therapy, right? I'm going to think about their neck, craniosacral stuff, and make those referrals out if they aren't already coordinated. So I at least am trying to teach our students that and coordinate that within our care. Across Canada, I think there are some relationships like that work, and I think we're trying to educate and increase them, but I think there's still divides and gaps for sure. And I'm trying to collaborate actually with Kristine Schneider and a few other on some of those pieces, how we better flag, do some work on how do we identify who needs vision, who needs vestibular work, who needs combined work, and how do we facilitate the pathways better.
Yeah, no, that's great. Because, oftentimes, even as, neurologists, we're kind of struggling because their symptoms largely overlap. And, that word dizzy comes
Yeah.
about when you can't see, but also if you have an inner ear problem. And then you hear their therapies and you're thinking, they end up in this kind of therapy. So, yeah, so great to hear that it's trying to integrate that.
I'm trying.
Thank you.
I mean,
First of all, thank you so much for the presentation. That was fantastic. I just had a quick point. So earlier in your presentation, you mentioned that optometrists are not usually involved in the acute phase, but usually in the persisting phase. So then my question would be, do you think that they should be more involved in the acute phase? And do you think that that could be helpful at all?
That's a great question. I struggle right now, even as much as I'd love for every person who gets a concussion to get a good eye exam, to think that that's really the bright lights, the dilation, that full in-depth assessment is really what they need the first 2 weeks post-injury. I think that we can wait a little bit. I think right now the VOMS is being screened and it's flagging, some of those acute screening tests are flagging people who might be at higher risk of vision disorders, and maybe those are the ones you watch closer. But I think right now, still in that kind of 4 to 6 weeks out, if vision symptoms are starting to persist or become more prevalent, that's a time to start engaging with optometry. I don't really think we need to be there within the first 7 years, as much as I'd like to be.
Yeah, appreciate that.
thank you. Dr. Ansari?
Great presentation, thank you.
you.
I was wondering if during your research you came across, there's a clinical trial apparently ongoing in UHN, ORCA, in Hall Ellis. Have you heard of that? Like I've
No.
recently known about it and I was wondering if
I haven't heard that one, but I'd
Yeah,
be curious to
it's-
learn more.
visual rehab. So yeah,
Yeah.
I'm looking forward to that because apparently it is a randomized clinical
Very cool.
trial.
Very cool. Very exciting to see.
Dr. Ritter?
Thank you so much. As you said, the field of optometry is quite varied, and it also has a varied reputation, right? One of the 2 points of criticisms that we hear a lot is that number one, if you send a concussed patient to an optometrist, you can be sure she will find something. Like there's always something. And number two is that then the patients are kept. They will get this vision therapy program, and it will sort of continue. I'm not saying forever, but for longer time than. Yes. So my question is, would you think when would you think that we should stop optometry treatment?
That's a great question, and one that I am struggling with in my profession, because I don't think people should be doing therapy for 8 years and not making progress. I really struggle with that myself, with my own experiences with rehab. I always tell every single one of my patients that the vision assessment, worst case scenario, we find nothing wrong and you just take vision off your worry list. It's not often, but occasionally, handful of patients, I don't find any visual disorders. I'm like, great, this is clean. See you later. Go focus on other stuff. When it comes to stopping vision therapy, that's part of the reason we're trying to do some of the studies that we're at, looking at what's currently being done and kind of where we're falling. I have lots of conversations with patients up front that it may not work for them, or they may reach a point and then plateau. And I really pay attention to those frequent reassessments to see if their numbers are still changing. If not changing, the patient's statements and symptoms have been stagnant, then that's really a patient where I need to have a conversation about, this may be as good as it gets for you spending the rest of your time and money in therapy isn't the best use. You know, enjoy the progress you've made and move on. And I'd like to be able to work in that evidence and pull out that vision therapy to facilitate those conversations, because I think they need to be had. Thinking that everyone can get 100%, I think is unrealistic. And we need to be, as optometry, willing to step away and say, you've plateaued, time to invest in other energies or enjoy what the progress.
Like we would do in rehab therapy in general. Yes.
Yeah.
I just wanted to mention that in Denmark, we are actually 2 clinical trials ongoing in vision therapy, both in a randomized design and yes, so watch out for whatever is going to come out the next couple of years.
Terrific. Thank you very much, Dr. Dalton.